I want to believe that you can now see the presentation that is on your screen. Yeah.
Yes, we can.
Thank you. So I'll spend a bit of time just talking about osteogenesis imperfecta, the basics to understand it. I'm hoping that somewhere between 30 or so minutes, we'll be able to finish the discussion. Then after that, we'll invite questions. There are some people who had already sent in questions to the wall earlier. We'll start by answering those ones. But then along the way, as I go along, if you have a question, please post it in the chat so that when we are done with the discussion, we can answer that question. So as introduced, my name is Dr. Levis Nguku. I'm working for the Machakos Orthopedic Clinic, and I've been here, I guess, for the last 8 or so years. So we'll start off on this discussion of today. Let's see. So what are we going to be discussing? Talking about what is osteogenesis imperfecta. We'll look at what are the causes of the disease. We're going to talk about the various types that we'll want to know how a diagnosis is arrived at when this is osteogenesis, and then the various treatment options, and just have a short talk about how to live with osteogenesis imperfecta, whether you're a parent or as an adult. So sometimes it's abbreviated as just I. It's a genetic bone disease that usually prevents the body from building strong bones. Other people will call it brittle bone disease. So if you search online, and there is a lot of material online about osteogenesis imperfecta. Some will call it brittle disease, others will call it OI. You'll find it in different names. It tends to affect about 1 in every 15 to 20,000 children that are born. And there is no difference between whether they're Africans or Caucasians or Asians. It tends to spread all around the world. Some parts of the world where you have a higher aggregation of patients, where you find osteogenesis imperfecta is more in that area, but generally around the world, the disease is there. To understand it a bit more about what causes it, it's a genetic disorder. Genetic meaning that it is not somebody doing wrong that it appeared. It is not a bug, it's bacteria. It is not an injury. Genetic. And usually what happens is a change in one of the genes that control production of a protein that is called collagen. Protein is the one that builds a base around which bone is built. To try and understand it, when you look at that picture there, it's of a bougainvillea fence. And that fence is creeping up a chain link. Many of you have these in your compounds or in your estate. So the protein is that chain link. Without the chain link, that bougainvillea will only remain on the ground. It will never go up because bougainvillea is not a tree. So when that chain link is missing, then now the bougainvillea can never be as beautiful as we see it. And it can't be the screen that we put on our walls. So think about the collagen the same way. With the collagen being defective in how it is built, then the bone does not have its normal strength because the base around which the bone is going to be built is not working well. This change may be inherited or something happens on its own. So for those that it's inherited, you'll notice that there's a parent who has it. But for those that it happens on its own, you'll find that both parents don't have osteogenesis, but then the child ends up with osteogenesis imperfecta. And so this is what happens. In a lot of the types that we're going to be discussing in the next slide or two, we find that the inheritance pattern is what is scientifically known as autosomal dominant. That usually means that when one parent has a condition and the other parent does not have the condition, the children that are born from there, half of them will usually have the condition and half will not be affected. And so if you end up with 2 children, there is a possibility that one of those 2 will have the condition. If you end up with 10 children, there is a possibility that 5 of those 10 will end up with osteogenesis imperfecta. When we still talk about what causes it, now the poor bone structure leads to deformed bones. And that's why we end up with X-rays that show bones that are deformed in that shape. That deformed bone usually easily breaks. That's why we end up with the bone being brittle and leading to more deformities. Some of those deformities can be in the hands, can be in the legs. We tend to see the bow legs and the bowed hands, and also we tend to see it in the back, causing a bent in the back, what we call a scoliosis. That bent in the back in some of the children or adults will notice it causes the hip to be twisted, and so you end up with one side of the hip looking like it's a bit higher than the other side. So something similar to what you're seeing in this child, that one side of the hip might end up looking like it's bigger or higher than the other side. And that's just because of the bend that is there. There are different types of osteogenesis imperfecta. Actually, scientifically, we talk about 19 types. But then here, we're not going to talk about all the 19 types. We'll talk about the 4 that are very common. Many of the remaining 15 or so are slight variations to this one, to these 4 that are here. The first type, the first type of osteogenesis imperfecta is what we call a type 1. Many of the patients with type 1 osteogenesis imperfecta do not have many fractures. In fact, sometimes they can go through most of their life with just the normal type of fractures that others will have because of climbing mango trees or doing whatever else. But the one thing that we tend to notice is that their eyes are bluish, what we are calling the blue sclera. So when you look at the white part of the eye, we notice that it is looking blue. Type 2, unfortunately, is very severe, and they start getting fractures when they are still in the mother. Sometimes, not sometimes, most times they don't even make it past a few days of birth. So it is lethal, and many children don't even live past a few days. Most of the people who end up coming to us as doctors, they are either in the type 3 or the type 4. So you'll notice that many of the ones who are in the type 3 have a progressively worsening type of osteogenesis imperfecta, because you end up with the fractures becoming more frequent, you end up with the deformities that are becoming more noticeable, you end up with somebody who was walking, maybe ending up on a wheelchair. And that's the type 3. They're the ones who end up mainly coming to us. And there's a type 4, which is just slightly worse than the type 1. And the difference we notice with them is that their sclera is not white, is not blue, it is whitish. So it's a more severe type of type 1. How do we diagnose? Diagnosis can actually start from before the child is born. And usually it's by the use of an ultrasound. Using the ultrasound, we're able to see whether there are already some deformities that have happened within the womb, or if there is even a fracture. Because remember, we said the very severe type 2, these fractures even within the womb, and those ones are noticeable on ultrasound. After birth, which is where we diagnosed most of ours, after birth, they tend to come with frequent fractures. X-rays will show either a currently broken bone or one that had broken and now it is healing. We tend to notice the blue sclera, and what I was showing, the blue sclera is what you expect in the eye to be white is actually looking bluish, or sometimes when it's very blue, we say it's dark gray or light gray. So it's looking grayish or bluish. Sometimes you can do genetic tests to check for that bone protein, which you call collagen. And those tests can also be accompanied by a skin biopsy, where we take a small portion of skin and take it to the lab and also test for the protein, whether it is present and if it is in its normal constitution or not. But most of the times will depend on the history of the frequent fractures, the X-rays that we see, and the color in the eyes. Another common thing that we tend to notice is there's a change in and rotting early when a child is still young. So, what are treatment options? Osteogenesis imperfecta does not have a cure. So what we do is we manage the osteogenesis. And in this management, we need a team to be able to manage it. And the team will consist of different people, an orthopedic surgeon, because we need sometimes to be having surgeries. We need a physiotherapist and an occupational therapist because we need muscle to be built. We need pediatricians because one of the biggest issues that we have with osteogenesis, especially type 3, is that the chest does not expand well because it is deformed. And when it does not expand well, we end up with recurrent pains, we end up with homa and pneumonias. And so we need either a pediatrician a child doctor, or if it's an adult, we need a physician or a chest doctor to be able to handle them. And then, as we mentioned, we also tend to have issues with teeth, and I'll be talking about it in a short while. So we need dentists in the team. And so the management starts with prevention of fractures. And what we advise is that we prevent activities that predispose to risk. Those activities are mainly sports. But besides sports, kuna ile mchezo ya watoto ya kawaida. They'll be at home playing hops. It was called hopscotch. The hop, skip, and jump. And when you look at that picture, a lot of you played this when you were young. But you see, something like that, a child will fall and break from there. And they were doing a normal thing that other children do. Other activities, you know, boys are rough. They're sling and they'll try rugby, which they saw somewhere else. They'll try climbing trees, sometimes riding bicycles. And you know, when you're learning to ride a bicycle, there's so much falling. So we try to prevent them from doing this and give them alternate activities to do. Because once you tell a child don't play, that's not enough. They actually need something to do because they have all this energy and they need to burn. Because remember, these children, their problem, the cartilage, it is not in the head. Their heads are fine. They understand everything and they see other children playing and they want to also play. So find them alternate activities. Then after that, we also need our physiotherapists and occupationalists to come in because we need the muscles to be strengthened so that it can help them to walk for longer. Remember when I talked about a case where a child ends up on a wheelchair? If they undergo physiotherapy and occupational therapy, one of the things that will happen is because the muscles are stronger, they can keep walking further and longer. So if, let's say, they would have ended up on a wheelchair by the age of 13, maybe they can go until 16 or 19 because before they can end up on the wheelchair. Then they'll also be taught motor skills, them to do their usual activities of living. There is a story that I see, a child with osteogenesis imperfecta. Some may already have seen it. For those who have not, just watch for a minute.
My name is Ifya Ayyaramati. I am 8 years old. I have osteogenesis imperfecta, which means my bones are soft and can break easily. Yeah. I like sing. I also love to play. When I broke my bone, I was very thankful. If I train, then I will break my bone. If I stretch my arm, I can break my bone. Yeah.
Really, I saw you doing something.
My bone. My mom will put something, then she rub it, then it will heal it. Heal. Yeah. Because I just trick my arm like everybody does. But with the help of God, fix my brain. I can do great things. Yeah.
So when you're talking physiotherapy, you can see the benefits of the physiotherapy and occupational therapy. That this child is to continue playing because we are strengthening our muscles as we go along. The other thing about management is medication. There's a group of drugs that we call bisphosphonates used to strengthen. What they do is that they stop the cells that weigh bone, the strengthen bone, build bone, and continue working. And when we started in Machakos Orthopedics to give patients one of the first one there written on it, we started about, I think, 2018. That's about 5 years ago. And the drug we started with was pamindronate, which we would give every 3 months or 4 times a year. And for us to give, we would have to be admitted in hospital for a 3-day admission, because we would give doses on 3 consecutive days. And they go away, come back for another dose 3 months later. And over time, it became difficult to access permethrinate. It was out of stock in most of the country. We would have to import from abroad. So eventually we switched to zoledronic acid. And that's what we've been giving our patients for the last about 2 years. And the advantage that we've had with zoledronic, and the big advantage with it, is usually that you just give twice a year. So every 6 months. The patient does not need admission, because it's given for just about an hour to 2 hours. And so it's a day procedure. In the questions that had been asked before, there was a question about this zoledronic acid and what would be the side effects, because somebody, I think, had been given that. And one of the things we notice is that they tend to have after we've given the children, they tend to have a headache and a fever for about a day or 2. And that's a normal reaction that has been seen in many patients who are given this group of drugs. So for a day or 2, they may have that. And so just by use of Panadol or Brufen, that is usually taken care of. And for us to introduce the patient to the drug, the first dose, we usually give half of the normal dose required. And then when they come back 6 months later, that's when we'll continue giving now the regular dose they're supposed to have. The other side effect we've noticed is that there is usually a reduction in the amount of calcium in the blood that needs supplementation. And the supplementation may be diet or maybe tablets. And it's only around the time when we give the drug for the first week or 2. And after that, the levels come back to normal. It's a side effect of the drug. Many people don't even notice it. We don't have any other major side effects. We tend to from as early as possible. There is documentation of patients who have been given as early as 3 months of age, and we tend to give it for as long as possible, because for as long as somebody is alive, we are still having the same problem with the building of the bone. And so we tend to give it for as long as possible, even into adulthood. The third option is usually surgery, among the things that we end up doing for osteogenesis imperfecta. And it's common after any fracture. Sometimes we'll also be doing it not because of fracture, but because there's a deformity that has occurred because of recurrent fractures in the past. We tend to use rods, and I'll be showing you a picture in a minute or so, which are driven into the bone marrow of the affected bone. And we tend to avoid plates and screws. And the reason we tend to avoid plates and screws is when you look at this picture on the right, this is a plate that was put for a fracture on the thigh bone, the femur. And look at what has happened. The bone has broken right next to the plate. And that's what we tend to see with patients with osteogenesis imperfecta, that the plates tend to break just next to where the bone tends to break just next to where the plate ended. When you look at this picture on the right, somebody else had a plate and the bone just started bending. This one survived long enough, but the bone started bending just beyond where the plate is. And so we tend to prefer putting what we call rods of one form or another that go into the medulla or into the bone marrow. Then that one holds the bone better. So for a long time, we have been putting what we call rush rods. There are these metals that have a hook at the end and it goes into the canal. And the problem with that is we are putting this rod in a child who is growing. And so after a while, the bone grows longer than the rush rod, and then they break just where the rush rod ends. And you end up having to repeat a surgery every 2 or 3 or 4 years, because for as long as the person is growing and the rush rod is not growing, they end up with that problem. And what we are trusting God for is that we're able to change and start using these other types of rods that we call growing rods. Because the advantage of this is that once we have fixed it on the bone, it tends to grow with the child. What you may notice here is that this metal up here is wider than down there, meaning that as the child grows, the part that is narrower tends to be more and more exposed. And as it gets exposed, it allows bone to continue growing normally. And this requires about 5 to 6 years before we need to change. So you can imagine a child that is about 6 years old, we are doing surgery on. Maybe we'll end up repeating surgery at about 12 years, and that's it. So in the whole childhood, they've only had 2 surgeries on a bone, while with rush rods, you easily end up with 3 or 4 surgeries on the same bone because the metal is not growing in the bone. The question becomes, then what is the role of parents in all this? And for me, I feel like the main role of the parents is actually to just remember to take them to the places where they're getting care. So if it's a scheduled appointment for the cyclical injections, take them for it. If it is to review after surgery has been done, take them. Because sometimes we end up with complications along the way. Maybe as a metal has dislodged from the place where it was put, or a plaster has become loose, or a plaster got wet because the child peed on it. Those are normal things that happen. And when they happen, we just correct them. If your child is not on the cyclical injections with epamidronate or zoledronic acid, consider them being started on it. And I've seen on the wall that, on the WhatsApp wall, that Dr. Specky had also posted that we have some zoledronic acid in the clinic. And so if a child is not having, get in touch with us and start on it. It makes a difference. There are those who have been started on it. And I remember like when we started with the epamidronate, children with fractures 4 times a year would now even up to 2 years without even a single fracture. So it makes a difference. It will reduce the number of fractures, and therefore you reduce pain, and therefore you encourage, the more encourage walking and to walk better. So these are that we see when you have less, it also means fewer deformities. It means if a child was to get scoliosis, they may get it, but it won't be as bad, or they may scoliosis. So we have better outcomes and better when they are getting their medication. And then finally, also teach the children on how to prevent injuries, and even what is this osteogenesis imperfecta. You've seen from the video, this girl is 6 years old and she knows what osteogenesis imperfecta is. She knows why her elbows do not stretch all the way. Let the children understand this, because they'll be able to take care of themselves better when they understand it. What about those who are already adults? Over time, most likely they have learned how to live with osteogenesis imperfecta. But then some of the things to remember is sports. To get engaged into sports that are not impact sports, and so they will not strain or stress the bones. Things like motorcycles and bicycles. It is nice to learn to ride this, but then we know that bicycles have higher rates of injuries because you will fall, you will slip. We know that motorcycles of all forms of transportation has the highest rates of accidents. And if people who don't have osteogenesis are getting fractures very frequently, how much more somebody with osteogenesis? And then just adjust activities that tend to strain the heart or even increase the risks of fractures. You know, unfortunately, even some of these activities may even include sex. Be involved in or have sex in ways that don't strain the heart so much, or put somebody in a situation where you end up fracturing when you didn't intend to do so. And then finally, be part of a support network. The WhatsApp group is a very good idea because you get to hear what other people are going through and realize that there are others who are like you. I remember there's a lady who joined the WhatsApp group, I think sometime early this year, and she was saying she thought that her child was the only one with that condition in Kenya. Then you come to meet others who are going through that, and they get to support you in various situations that you may be having difficulties. Finally, I just mentioned a few other concerns that people tend to have along the way. Pregnancy. Can one get pregnant when they have osteogenesis imperfecta? Yes, they can get pregnant and deliver babies, but then you need to be aware that there's a risk of a premature delivery. It has been noted that the babies sometimes tend to come earlier. Secondly, that this baby is also very likely to get osteogenesis imperfecta also. You remember the chart I showed showing that 50% of the children with somebody who is affected are likely to get the same. So you need to be aware that there is a possibility that the child may also have osteogenesis imperfecta. If one is planning to get pregnant, then it's advisable to stop the medication somewhere before getting pregnant, to about a year before getting pregnant. And then even during the period of the pregnancy, it is important to use calcium supplements before and even after the conception. Another concern people raise is about diet and weight loss. Is there any particular diet that somebody should use? No, not really. But a calcium-rich diet is useful, especially around the time when there are these cyclical injections that we are giving. Because we've said the injections tend to lower the blood calcium. So having a calcium supplementation, whether by diet or using calcium supplement tablets, may be beneficial. And then if you're going to talk about weight loss, then what is advisable is low impact exercises such as swimming and dancing, because at least those tend to be safe and they don't lead to a higher frequency of fractures. And then finally, other concerns are about dental problems. Talking to dentists, they usually advise us that if a child with osteogenesis or even an adult with osteogenesis comes to them, they can put crowns. And when you look at picture A, you see the deformities and the rotting in the teeth. And look at picture B, those are not the child's natural teeth. Those are crowns. They are artificial, they have been added, and they have put a size that is big enough to allow, as a child grows, the other teeth will come and join at the same size of teeth. And so when they have put this crown, it can be there for 10 to 20 years without any issues. And so consulting a dentist when a child has these problems may be beneficial in helping the child, even in self-esteem, when they see that they have normal looking teeth. I'll stop there and allow us to be able to ask questions. So maybe I'll hand it back to you, Dr. Specky.
Thank you so much for the presentation. I can open it up to any questions. If you have any questions, you can type it on the chat. But I can start with some of the questions that were previously posted. So one of the questions that someone asked was, someone told me that people with osteogenesis are more exposed to getting high blood pressure. Is that what? Can you comment about that?
No. Osteogenesis imperfecta is a problem with collagen that affects the growth of bones. So when you look at all these things we have talked about, it's all affecting bones. Teeth also have some high level of calcium in them. And so that's why we end up with problems with the teeth. And so no, people with high blood pressure, whether they are osteogenesis or the general population, the rate or the frequency is the same. We don't find it more in the normal population or higher among osteogenesis.
So since it's a condition that affects bones, there was a question which is related to that. Someone asked that could they have a blood problem because their bones are the ones that are short? So could that affect their ability to make red blood cells and white blood cells, since this condition affects the bones?
It affects bones. The condition affects bones structure. It does not affect the making of the blood, because the process of making of blood is a totally different system, which is in the bone marrow. And the bone marrow, as you may know, it's a very spongy and soft bone, so that's not an issue. And the other thing is, a lot of blood formation, by the time somebody is getting to early teenage, has already shifted to a very small area of bone, which is usually just around the chest, the sternum, this bone right at the center of the chest, and the bones of the waist. So all these other bones in the hands and the legs, they don't even participate in the formation of blood by the time somebody is getting to teenage. So no, it does not affect the blood. And even when we do the blood tests, like for the patients who we are planning surgery, whenever we do the blood tests, we don't see any abnormality that we can relate to osteogenesis.
Okay. Someone is asking a question. Is osteogenesis categorized as a permanent disability? That's from the chat.
Yes, because there is a limitation in what somebody can do as compared to the general population. It will be categorized the same as deafness. It will be categorized the same as blindness. the same as somebody who has lost a limb, whether born that way or through an accident or some other cause of surgery. So yes, it is a permanent disability.
Yeah. Maybe I can, before I can read any other ones, maybe you can, if there are people who would want to ask a question, maybe you can raise your hand and unmute, and then you can ask the doctor directly. I think that video that you had shown, I don't know whether it was just in my part here, but it was not clear. It was breaking a lot.
What I can do about the video is I can share it on the wall. I can share it on the wall so that those who are not able to see can see it from the wall. I'll do that in a short while. Actually, I can just do that right now.
Good evening, everybody. If nobody is asking a question, can I make a comment and ask a question later?
Sorry,
Well,
I can't hear you clearly.
I said hello. Is it okay if I make a comment or make a statement and ask the question later?
yes, please. You can make a comment and ask a question.
Yeah. First of all, I want to say thank you to the doctors and to the organizers of this meeting. I think I'll start by introducing myself. I am Tarela Gante, and I also run an Osteogenesis Imperfecta Foundation in Nigeria and also in the UK here. Also in the WhatsApp group. Actually, that WhatsApp group I did started that WhatsApp group to put all the aim was to put all OI members together so we can get help with a lot of members. Now, I want to say thank you to the doctor because a lot of stuff that you've actually said here are spot on. In fact, all of it is really spot on. I was just following through and just hearing, and I'm so excited and so glad that something amazing is already happening in Kenya. I can relate to a lot of stuff that you said, but I think the major thing that I want to say is to also to all our other OI people is we need to be, as the doctor said, that the medication is very, very important for every OI person. It's truly important because in the race of running this, the process of running the OI organizations that I do, I know a lot of parents that have actually stopped their children from having the bisphosphonates infusion. And I must tell you that at the end of the day, that it has come back to bite them, because that can actually stop you from not having the corrective surgery if at the end of the day you need it. Because quite a few of our children were not able to go through with the corrective surgery that we planned in October, just gone October, just last month in Nigeria. And that was because some of them were not on bisphosphonates medication. Their parents had actually stopped them. And because their bones were just too fragile to take on the rods. So the doctor didn't think it was right for them to have surgery. So I want to appeal to our members on here people with OI that it is the importance to stress on the importance of having this medication. So the opportunity is out there for you to have the medication. Please go for it. Because I know one thing that a lot of Africans do is we are too spiritual and think medication is not for us. They are thinking of, they are wishing for a miracle to happen without going through the process of healing. So I just want to, encourage everyone to take this opportunity and go ahead and take the medication. As the doctor said, you've heard the side effects. There are no major side effects. It's only you will have what do they call it? Temperature, headaches, and in fact, from my own experience, within a day or a few hours after taking the paracetamol or ibuprofen, it all dies down completely. It all goes. So there are no major implication or side effects to having bisphosphonates. And I can testify to what the doctor has said, that if my child has got osteogenesis imperfecta, and he was on pamidronate and then moved on to zoledronic. And I can tell you that he stopped zoledronic now because of the age. He's been taking it for only God knows when. And for the past few years, they stopped it. And I can tell you that since he has been on the medication, the rate of fracture really drastically reduced. And for the past 5, 6, 7 years, my son has not had any fracture because he has been taking his medication and bisphosphonate. So just to buttress on the advantage of being on the medication, it is very, very crucial and very, very important. So I really want to encourage everybody. You've got the medication, you've got the opportunity to take the medication. Invite a lot of people, a lot of other OI people to take it. And ourselves, we should go ahead and take the medication. There is no doubt about it. I personally, with my son, have gone through the process. We are very fortunate to have had the process done. And I can personally testify to the advantage of having the medication done. So even if there is opportunity for surgery, go ahead and have it. It is very, very safe. The doctors know what they're doing, and it is very, very advantageous. So just to put that out there. And hopefully my aim is to work with our doctors in Africa to see how we can support a lot of OI members, OI people that are suffering from this condition, to get them help. So hopefully we will get that done. But my question today is to ask about the surgery. Well, I think I should leave the question. I will have it. I know the answer to that is just to help other people that don't know. But I think I will have a word with the doctor and the organizer of the organization, so that in the future we can have more of this event, or this the online education done with a lot of Kenyans and a lot of OI people in Kenya and across Africa, really. Thank you so much.
Okay, I can still encourage you to ask the question, because you usually say, even if it's not for yourself, you could be asking for your neighbor.
That's so true. That's so true. Yeah. Okay. The question I was going to ask about this, it was on surgery. What is the importance? I just wanted the doctor to stress on the importance of having the surgery, and after surgery, is there what is the rate of success of a person that is gone through that surgery to start walking without being on wheelchair or using a mobility aid?
Yes, Levis, maybe you can help us answer that question.
Yes. Today morning, we had surgery on one of the children with osteogenesis imperfecta. 3 months ago, he broke his tibia. And because it was a very small break, we said, oh, this one should heal in casts. And so we put him in casts. He's done 3 months and we still see the fracture gap. And because of the fracture gap, he has continuous pain walking. So obviously at home, he doesn't walk much. Today, I know because we have put a rod in him, in a month or so, he will be walking again. And because the fracture will heal quickly, or at least it will heal not only quickly, but also straight, he will not be in pain. And so it will be easier to use those crutches that he's using and not be tempted to go towards a wheelchair. 5 years ago, when we started giving Pamindronet, it started with 2 children who had gone for surgery out of the country. And a lot of work was done on them because they did both tibias, both shin bones, and both femurs. And they put rods on both of them. And one of those children had not been walking because of the deformities. From there on, that girl has been walking until today. We have seen her approach teenage because I think she was about 5 or 6 when the surgeries were done, either 4 or 5. And we are seeing her approaching 10 years and she is still walking. We saw her friend degrade because of failing to continue with Pamindronet, developing other deformities, which the mother refused to bring the child for treatment. And we just saw the friend going down, and this other girl who had the 4 rods and following Pamindronet continuing to walk. It's a world of difference. It's day and night. That's how different they are. And so when we say we are talking about doing surgeries, the surgeries are meant to make the child better. We should not do surgery to continue keeping you on a wheelchair. Our aim is to try and improve the ambulation, the ability to walk as much as possible. And we have seen it happening with others.
So there are 2 people who've raised their hands. There is Joseph Ngugi, and I think JB at some point you had raised your hand. So maybe Joseph Ngugi, you can unmute and ask the question.
Thank you, Dr. Specky and Dr. Levis, for the good presentation. I am a parent of a baby with osteogenesis imperfecta, and we are currently doing the zoretronic. I said that is 3 monthly. The baby is about 1 year, 3 months now. He was born with a deformity on the left leg, the ankle and the knee joint. So I was asking, how soon should we consider maybe a surgery for correcting the same, and how necessary is it? Because in a reached a point whereby, you know, a bit of anxiety, like he might be delaying his milestone and so on and so forth. So maybe like an advice or hear from the doctor on how soon we can consider a surgery to do the corrective so that he doesn't get delayed in other milestones. He's already sitting, but he's not able to do maybe crawling or so because of the leg which is deformed. Over to you, Dr. Specky.
Levis, please help us with that question.
Okay, so you said the baby is 3 months old. The last statement I made on answering the previous question is our surgery. Sorry?
1 year, 3 months.
Or 1 year, 3 months. Okay.
Yes.
So the comment I made when finishing on the previous question was our surgery needs to help the patient to move from one step to another. And so the first question would be, is this deformity limiting crawling? Is it limiting walking? We know that children who are born with osteogenesis, especially type 3, there is usually a delay in the milestones. That one we know. But for as long as you're making progress forward, we are not usually worried because eventually they get to the walking and to the running and the like. So an assessment should be done to see whether it is the deformity that is causing that. But then now that you say is 1 year and 3 months, any other child of 1 year and 3 months would at the very least be standing. And we expect them that by the time they're getting to 1 year and 6 months, they should be walking. So I have a general inclination to encourage you to go towards the surgery because that will straighten the limbs and therefore allow weight bearing. Because a child cannot stand when they can't bear weight on that leg. And so I would incline you towards going for the surgery. But obviously, after an assessment from a surgeon saying, if we straighten this leg, we expect that this child should stand on it, unless there's something else holding them back.
Okay. JP, I don't know whether you still have a question. At some point your hand was raised. Sorry, we can't hear you. I think there's a lot of interference. I don't know whether if what could be happening. Could you possibly just, if it's not clear, can you please type the question? Or try again, because we can't hear you clearly. There's a lot of background noise.
I think her internet is not 100%. So I think what she should do, or he should do, is to text his or her question, and that can be taken.
Okay. So JB, please kindly text your question so that at least we can hear you. We can get your question. As you're doing that, let me ask another question that was also asked previously. Someone has asked that they have read that blood transfusion helps people with OI. So what exactly could they be looking at, could be happening?
I'm not sure what kind of blood transfusion they may have heard about, because a lot of times we talk about blood transfusions for blood-related conditions. So we'll talk about it for cancers of the blood. We'll talk about it for basically blood-related conditions. But there was a study that was done. Somebody was trying out some experimental thing with blood transfusion, and not just whole blood, it was a component of blood, where they would just be talking about plasma. And see, if you do frequent transfusions for a child with osteogenesis imperfecta, if it makes a difference to certain proteins, which eventually will result in improved bone strength and therefore better walking. And the conclusion of the study was eventually that, yes, it would make some difference, but then you would need very frequent transfusions, sometimes quoting something as frequent as daily. Now, obviously, we can't be taking our children to hospital every day for blood transfusion when we know there's an option for giving an injection of a drug once every 3 months or once every 6 months. We know we have those options. So this experimental blood or blood component transfusion was not that successful, and I would not encourage people to go that way, because it's still something that is under trial and under investigation. So I'd rather go with the tried and tested.
Okay. There's another question that was being posted in the chat. How long can one live with this condition? Like, what is the longest lifespan?
As long as God gives you. Depending on the type. We know that type 2, we hardly ever get to see those patients because they either die in the womb or just soon after birth. 60% of the patients born with osteogenesis imperfecta are type 1. And remember what we said about type 1 is that it's a very mild form. We only tend to notice that they have blue sclera, and occasionally they'll get fractures. Sometimes you'll just say it is this naughty boy who keeps falling off trees, and that's why he keeps breaking the hand or the leg. And they live their normal life, full lifespan. That's most of the patients of OI, which is 60%. The rest are now scattered in the type 2s and the 3s and the 4s. And you know that type 4, they are also like type 1. They also live a full lifespan, no interference at all. Sometimes we have problems with type 3s, and not just because of breaking a bone, because a broken leg does not mean somebody is going to die any sooner. It heals. It may have some pain, but it will eventually heal. But the problem we tend to get is with the chest, because when you have a deformed chest, the breathing is limited, and they even complain of some chest pains. And when breathing is limited, it leads to somebody having pneumonia. And when you have pneumonia repeatedly in hospital, we know that there is a higher chance of mortality if you are recurrently going to hospital with a certain condition. Because what takes them to hospital is not the osteogenesis, it is a pneumonia. So the bone in itself does not limit lifespan. It is the complications of that can limit the lifespan, and especially with type 3s and the chest problems.
Also, there's also there's those, I think there was a video that I once saw of a man who is 70 years old with osteogenesis imperfecta, and it was type 3. He actually lives a very, very productive, he seems to be, of course he lives his life with some limitations, but it doesn't seem to have stopped him, and living up to 70, I think, is an example. Yeah. Yes, there's another question that has been posted here. Let me read it.
If I just make a contribution to that, is that okay?
Yes, please.
I know personally of patients with, the doctor is actually right. I know personally patients with type 3 that have actually lived up to 70 plus. So it is very possible for any patient, whether type 1, type 3, type 4, and type 20 or type whatever is out there, to live a normal life, or to live to the highest number of life that they can live, if there is proper maintenance. So even with the type 2, I know, especially in Africa, it might be a bit tricky, but type 2 these days are beginning to survive, especially when they are caught quickly and immediately from birth, even during in times of conception, proper maintenance is being given, proper care is being given, and they are being born, they are diagnosed on time, and then the proper care continues. They can actually still survive, because I have personally met somebody that was even type 2 that has lived more than 20 years. So I was really very shocked to hear that, because from the initial time, having gone through OI myself with my son, I've always been in that awareness that type 2 don't survive. But I was shocked when I went to this conference in the UK here, and I found out a type 2. I actually met the guy, a type 2 did survive. So it's all about, for the whole of OI, is all about maintenance and care, proper care. Once there is proper care, you're taking your medication, you're doing the right things, just as the doctor have said, you can live to the longest of life that God has allowed you to live and to go on. Yeah, I just thought I'll put that out there.
So there's another question that has been posted on the chat. The question is, let me just read it again. Where could you shed more light about basilar invagination? I think this is related to some patients who maybe in osteogenesis usually get some problems at the base of the skull.
Yes, because we are talking about bony problem, we have an abnormality in the way the skull is shaped, where the brain ends and you start the spinal cord. I will not talk more about it because unfortunately that belongs to the neurosurgeons. And as you may have seen there, I'm an orthopedic surgeon, but we know it's a problem that occurs. And my hope is, as Tarela mentioned, that we may want to have more and more of these discussions. My hope is that in the due course of time, we can also invite a neurosurgeon to come and talk at the same time when we also invite a dentist to come and shed more light about the dental issue. So allow me to just skip that for now and know that, yes, it's a condition that occurs.
There's also another question that has been posted in the chat. I think this is by JB. Hello, can we get the same service of zoledronic therapy offered by MOC anywhere else in the country?
The answer to that is yes. Zoledronic acid is being offered in other facilities around the country. Joseph talked about his baby who has started receiving zoledronic acid every 3 months. And if I'm not wrong, that is not here at MOC. It's being offered at other facilities. So yes, the drug is available. I know several private hospitals have that. The difference will just be that in the other hospitals, they may not have it cheap or free. So there will be a cost attached to it. Currently at MOC, we have a consignment of a drug that we received from one of our partners. And so we're able to offer it at close to nothing. I think patients in the last group that they came, I think they were paying about 500 shillings for the dose for that day. And obviously that is not the cost of the drug. It's just to pay for the needles and syringes and things like that that are being used. So yes, it is available in other parts of the country. And within the group, I'm sure people can talk more about that and say where they are getting theirs and what is the experience in that place.
Okay. Okay, like I can also shed a bit more light about that. Currently in Machakos Orthopedics, we have 2 cohorts of patients, groups of patients. We have some who have been receiving it in January, July, and another group April, October. And so what we've been doing is that we would bring in a group of patients, maybe up to 20 patients at a time. And then they would come, and the advantage of them being done together is that you get to see other patients or other people living with osteogenesis imperfecta, and they're given the medication. And like Levis has said, they only charge 500 shillings, which is maybe $0.33 for the sake of Tarela. And that is just to pay for the materials that we use. And we thank God for that we've been able to get that consignment. And so we have space to recruit more. And so if depending on the numbers, we can start another cohort as soon as possible, so that at least we can reach to more patients. So if you are interested, kindly just reach out to us, and then we see how we can be of help. We share whatever resources that we have, and we're willing to share the zoledronic with the people who need it. Yes. Is there any other question that someone would want to ask? I think we're almost coming to the top of the hour. Is there any other question that someone might have? So since there are no other questions, we will try and share. I can share my phone number there on the chat, so that should you want to join our WhatsApp group where we're sharing information, we can reach out to more people. So kindly just send me a WhatsApp should you want to join our WhatsApp group, and we can also share information with you about OI and any other questions that you might have. So with there no further ado, I think I would want to close this. I want to thank Levis for the comprehensive meeting. I think it was quite informative and quite useful. Thank you also, Tarela, for also introducing us to the Osteogenesis Imperfecta Kenya group. And we hope that you can be able to count on your lots of experience to see how we can get moving forward in this country. We are looking forward to getting those growing roads, and hopefully as we get them, we hope that you can lobby the government that they'll be able to have this paid by social health insurance, so that more and more patients can be able to benefit from this. So without any other further ado, I would like, you are free to leave at your own pleasure. I'll just keep this open for a few minutes so that in case there's anyone needs to copy the phone number so that we can reach out to more of you. We have recorded this session so that there are some people who struggled to log in. And so we will put this up and send the recording to you so that people can be informed and may be able to make life choices. Thank you and have a good night. Maybe Levis, with some parting words, you can just end with some parting words and then you can allow us to leave.
I'll just say, let's keep the group active. Let's be able to ask questions. Let's answer questions. Let's help others who are hearing about this for the first time so they may realize they are not alone. There's a bigger community out there very willing to support. Thank you everyone for attending and have a good night.
Thank you.